Hello, it's Melissa Sweet and we're at the Rural Health Conference. I'll let our guest introduce himself.
I'm Harry Burns. I'm a Professor of Public Health in the University of Strathclyde in Glasgow in Scotland, but I have a history of being a surgeon, being a Director of Public Health and being Chief Medical Officer for Scotland.
How long have you been working to reduce childhood health inequalities?
Probably 30 years. I've been conscious of the inequalities problem, but I'm obviously slow in the uptake because it's taken me a while to work out what the solution to the problem might be.
And you presented some of those solutions to us this morning. Could you give us a summary, I guess, of what you've learned?
So the fundamental problem with disadvantaged individuals and communities is they feel not in control of their lives. They feel a lack of a sense of purpose in life, and just generally life is not great for them, and therefore they turn to smoking and drinking and so on. And the society's response is to shout at them for smoking and drinking, when in fact society would do well to look at the real causes of their problem, which is lack of purpose, lack of control, lack of a sense of optimism, lack of resilience. And a lot of that comes about through their experiences in early life. Children who experience chaotic lifestyles through domestic violence or parental mental illness or whatever have very definable problems in decision making and learning and so on. And that kind of chaos even influences the way some of their genes work. So politically, people will sometimes argue that these people need to make different choices, whereas scientifically we know that the circumstances in which they have lived make it difficult for them to make certain choices. So shouting at them won't work.
So tell us about the collaboration that you've been involved with in Scotland.
So instead of having top-down controlling type policies where the public sector does things to people and in doing so even undermines their sense of self-esteem even more, we decided that we would design change from the bottom up, that we would have frontline staff and citizens working together to achieve what mattered to them. We got communities together to talk about early years. They agreed what they wanted to change, by how much, by when, and the method that we put in place was very familiar to people involved in sport because it's the marginal gains approach. Do lots of things, see what works, and if you do what works consistently, you get a significant change in outcome. And using that approach, first thing we noticed was an 18% reduction over a few years in stillbirth rate, a significant reduction in infant mortality. Now, we couldn't point to any one thing that did that because we tried the frontline staff tested lots of things. And when the things that worked were brought together, we got that significant change.
What were some of the things that contributed, do you think?
Well, things like enhancing attachment and enhancing children's cognitive function. The example I gave today was bedtime stories. So the evidence said if children that get bedtime stories do better. So the frontline staff said, well, how do we know what kids get bedtime stories? We'll ask them. Every day, in every nursery, we'll ask them. So we knew from one day to the next how the bedtime stories were going and so on. And then they tried things out, different ways of cajoling parents into giving them bedtime stories, making it easy for them, supporting them with books, supporting them with gatherings where they would talk about the benefits of bedtime stories and so on. And they would track each day how many children were reporting they'd had bedtime stories, and it went up close to 90%. So these kind of things, different interventions associated with observations during pregnancy and so on to reduce stillbirth rate and all that kind of stuff. So frontline staff determined what they would try out, they tested it and implemented, they shared the learning and implemented at scale the things that worked.
When you say frontline staff, what type of people are you referring
I
to?
mean, health visitors, district nurses, midwives, GPs, anyone who was engaging with people. And we would have police at our meetings, we would have whoever was involved in community well-being, we would invite to these regular meetings. The meetings involved about 800 people meeting every 5 or 6 months and sharing their experiences over the past few months as to what worked. And it was up to local counties and so on to determine who actually came to those meetings. But the frontline staff were in the meantime being asked to test things. So it's the complete antithesis of a top-down policy coming from a government minister. At the end of a long process, we told ministers what was working, and they were content to continue to support that.
And is this a process that can be applied elsewhere? Is it something specific?
Well, it's a process that first of all came from patient safety, and before that it came from the car industry. It's based on the idea of inspections and so on not being the way to ensure quality, but to engineer failure out the system right from the start of the process. So it's got a long history in process improvement, but applying it to social circumstances has proven to be easy, popular, and successful.
You urged delegates today to break the rules.
Yeah.
What did you mean by that?
Because too many rules imposed in the system are for the benefit of the system, not for the person who needs help. For example, targets, indicators, spending constraints and so on. That's all about keeping the system out of trouble, keep us off the front page of the newspapers. And I gave an example of people who were costing the system a lot of money in terms of being arrested for being drunk and disorderly and creating public nuisances for themselves and having to go to accident emergency a lot and so on. And one person that I was hearing about recently who did exactly that had been arrested 30, 40 times for being drunk and disorderly. When someone had the intelligence to sit down and say, what matters to you? What do you need to live a better life? It turned out that this woman was living in a really dirty house. She'd become overwhelmed by how untidy it was, and that all she could do when she woke up in the morning was get out and forget about her house. So the question we would ask is, what's better for the system, arresting this lady all the time or giving her a home help one day a week? And at the moment the system would say, oh, we can't possibly spend that money, but you're spending a ton of money in the criminal justice system. So we are stupid is the only word for it in terms of imposing these rules when they get in the way of helping people.
And on that note, I just mentioned to you or asked you about Australia's policy of income management or welfare quarantine and the basics card. What was your response? What is your response to that?
It sounds to me as if quarantining benefits is government telling people what they can and cannot spend their money on. and that is undermining their sense of control even further, and that will make the problem worse. This idea that the answer is they drink too much, therefore we have to stop them drinking, therefore we won't give them benefits that they can spend on drink. In fact, supporting them to be in control of their lives is the way to get away from these kind of habits. And all the projects that I have seen that are based on the what matters to you principle, I will help you achieve it, spend far less on the individuals than the current system is doing in terms of benefits and so on. You suddenly find individuals begin to flourish, they begin to take an interest in themselves, they get jobs and so on. But when you're telling people they can't spend the money that the state says is theirs, that is Victorian in my view. Absolutely stupid.
Is there anything else, just thinking back to the discussion at the Rural Health Conference today, anything else that you would like to raise in light of those discussions before we wrap up?
I have been struck by the information on inequalities in the Indigenous population, and it feels to me that that's a group that's ripe for sitting down, discussing, and having this kind of improvement approach based on what matters to you. It feels to me as if there's lots of things happening in other countries that use this improvement approach that could be applied quite significantly.
Well, the Aboriginal community-controlled health sector actually leads the way in Australia in terms of community control over health services. So I actually think they have a lot to teach non-Indigenous Australia.
Well, that would be a help, but I mean, what I'm talking about is everything. Bring everything together. Bring education. Bring health. Bring job creation and so on, and sit down. And my experience is when you start that dialogue, local communities and local people will come up with really, really clever solutions.
Thank you very much for your time.